Welcome to the Peds Hub podcast. We are a group of paediatric trainees in the Southwest who every month review a selection of articles that we find useful for our practice.
These are taken from the BMJ, Archives of Disease in Childhood Journals.
For the full articles, please go to their website, journals.bmj.com. Please note, these are our own opinions and are produced for educational purposes only. They are not intended to substitute professional medical advice, diagnosis or treatment.
Thanks for listening.
Hi, my name is Paulina Connolly and I'm a paediatric registrar currently working in North Devon Hospital. Over the last few months, there have been quite a few research papers and reviews in Archives in Fetal and Neonatal about the neonatal gut microbiome, which is a topic of particular interest to me, so rather than just looking at one in isolation, I thought I'd chat through a few of them this month. My original intention was to include the paediatric microbiome as well as the neonate, but there's so much to talk about that I've restricted myself to the neonate for this episode. A good article to start with is the review in the July edition of Fetal and Neonatal by Wong et al. Called Manipulating the Neonatal Gut Microbiome, Current Understanding and Future Perspectives. The review discusses the development of the healthy gut microbiome, its disruption, or microbial dysbiosis, the links between microbiome and disease, and finally the potential for what they call microbiome engineering. Whilst most of our interventions, such as intrapartum and early neonatal antibiotics, have improved perinatal mortality, the new challenge is to rationalise use of them as far as possible, or compensate for them in order to achieve the least long-term morbidity. The predominant bacteria found in the neonatal intestinal microbiome are from four main phylum. Actinobacteria, under which nests the Bifidobacterium genus, forms the majority of the healthy neonatal microbiome. Then we have the Firmicutes, under which we find our helpful lactobacilli, but also present in this phylum are Staph, Strep, Enterococcus and Clostridium. Then we have Proteobacteria, which includes Enterobacter, E. coli and Klebsiella, as well as the aerobe Acinetobacter, and finally Bacteroidetes, which includes the Bacteroides genus. Many of these bacteria we well know to have pathogenic potential, but in the correct balance form part of the ecosystem which works symbiotically with our gut. The first disruption to this balance can arise even before the neonate is born, from maternal microbiome dysbiosis. Most of the causes of this are predictable, maternal ill health and antibiotics, but I was really surprised by the long-term impact a maternal high-fat diet was shown to have on pups' microbiomes in animal studies, lasting right through to adulthood despite having administered probiotics to the mother. It will be interesting to see what we find in human studies, but we do know that maternal obesity is linked with poorer child health outcomes. Much less surprisingly, the review commented on studies showing that maternal intrapartum antibiotics impacted the neonatal microbiome for 30 days following delivery. And this draws in another of the recent papers. The review in the July edition of Archives by Diamond et al., titled Impact of Intrapartum Antibiotics on the Infant Gastrointestinal Microbiome, a narrative review, found some papers demonstrating a reduction in bifidobacterium up to a year of life. It is worth noting, however, that there was a lot of variability amongst the outcomes of the papers reviewed, which, as always, suggests more studies are needed. The paper did introduce some new terminology for me, though: alpha and beta diversity. Alpha diversity is how much diversity is seen within a single specimen at any one time, whereas beta diversity is comparing specimens and seeing how much similarity or difference there is between them. Moving on then to the delivery. Colonization of the neonatal microbiome usually begins during vaginal delivery. The neonate is exposed to vaginal lactobacilli and bifidobacteria species, the latter of which is thought to also be picked up by maternal fecal exposure. Babies delivered by C-section have foregone this exposure and may have lower diversity, which can also lead them to have higher levels of facultative anaerobes like Clostridium species. Mothers undergoing C-section will sometimes carry out what's called vaginal seeding, i.e. rubbing their baby's face and/or body with vaginal fluids. There is limited data out there about this, and hence has mixed opinions amongst healthcare professionals. Some cite increased risk of infection, which can definitely be true, e.g. in known cases of primary HSV. But if there are no known infections, when you consider that around 1 in 3 mothers are colonised with group B strep, and many will deliver vaginally without knowledge of their status. Is it such a big risk versus a standard vaginal delivery? And when you consider the evidence suggesting increased rates of asthma and obesity in babies born by C-section, it seems worth a try when there are no contraindications, particularly given it is the cheapest microbiome engineering we can do. The next stage to consider is feeding method. As expected, there is an increased amount of healthy bifidobacteria in breastfed babies over formula-fed babies, which arises both from the breast milk and the areolar skin contact. Breast milk contains human milk oligosaccharides, which can only be broken down by bifidobacteria or Bacteroidetes, so essentially there is a prebiotic to promote growth of these species, reducing the risk of overgrowth of pathogenic bacteria. They are also in themselves hypothesized to act as pathogenic inhibitors. Similar to the other interventions, there are higher rates of obesity and asthma, but also type 2 diabetes and inflammatory bowel disease in formula-fed infants, even when adjusted for socioeconomic status. The review also comments on a paper stating a difference in the bacterial diversity of breast milk in mothers following C-section versus vaginal delivery, hypothesizing that labour itself impacts on diversity. However, the review admits that this paper had a total N of 10, so it's an interesting starting point, but not really one to draw conclusions from as yet. Loosely related to feeding, one question that has often crossed my mind was partially answered in the September edition of Fetal and Neonatal Journal, Effect of Prophylactic Dextrose on the Neonatal Gut Microbiome, by Sinclair et al. Whilst working in a lower-income country, it was common practice to give preterm neonates, and occasionally term neonates, oral 10% dextrose whilst awaiting maternal milk to come in. I've always wanted to know how much of an impact this has on the baby's microbiomes, particularly whether it makes much of a difference given the relative instability of most practices compared to our units. Anyway, this research paper looks at a much more locally relevant practice of giving small amounts of oral dextrose gel and analysing the impact on the gut microbiome. It is nested within a larger trial, hypoglycemia prevention in newborns with oral dextrose. The study administers a gel 1 hour after birth of 0.5 ml per kilo of either 40% dextrose gel to the treatment arm or a placebo of 2% hydroxymethylcellulose gel, then analysed stool samples on day 1, 7 and 28 days of life. They looked at both alpha and beta diversity in the groups, as well as total microbial load, community stability, and relative bacterial abundance. I won't go into the details of the paper, but in short, they found no significant difference between the control and the treatment arm. They did, however, find differences in diversity, as noted in previous studies, between babies born by C-section versus vaginal delivery, and formula-fed infants versus breastfed infants. Whilst this study looks at giving 40% gel, hopefully there's enough similarity to be able to extrapolate findings to the ubiquitous practice of giving 24% oral sucrose for painful procedures, and at least reassure us about the impact of this practice. And finally, on to antibiotic treatment of the neonate. This is a huge topic in its own right, and for the purposes of this discussion, I will focus on the preterm gut microbiome. As expected, early life antibiotic exposure impacts in a similar way to the other interventions, but more specific to the preterm is the risk of the potentially fatal necrotizing enterocolitis, or NEC. Preterm infants in NICU already have disturbed evolution of their microbiome, with a lower diversity of microbes seen. The reasons for this are many, from the obvious, regular antibiotic exposure, a relatively sterile environment with a higher risk of being exposed to resistant organisms, and then the slightly less obvious, immature absorption and altered gut transit time, regular periods of fasting due to concerns about feeding intolerance, and the slightly higher likelihood of administering stomach acid-reducing medications. There is a huge amount of research into the causes of NEC, but amongst the theories is the belief that a disruption of the gut microbiome plays a role. It feels instinctive, therefore, that probiotics should make a difference to development of NEC, which leads me into the final articles that I'm going to bring in today. Necrotizing enterocolitis, late-onset sepsis, and mortality after routine probiotic introduction in the UK by Granger et al. In the July edition of Fetal and Neonatal. This study came out after the Cochrane review and is larger than most of the previous studies, but is a retrospective cohort study with all the inherent flaws that they bring. they looked at 1,061 infants born at less than 32 weeks between 2009 to 2017. To the half born between 2009 and 2012, no probiotic was given. To those born between 2013 to 2017, they administered a probiotic, on average by day 6 of life. 70% of babies received Infloran and 30% received Labinic, as the unit switched to Labinic in 2016. They both contain Lactobacillus acidophilus and Bifidobacterium bifidus, but Labinic also contains Bifidobacterium longum species. They didn't analyse the different probiotic groups separately, which could have been useful if there had been similar numbers of babies. For the most part, the populations were not significantly different, with similar gestations, antenatal steroids, and rates of vaginal delivery. There were slightly higher rates of chorioamnionitis in the probiotic group, with 11% of babies versus 8%, but this didn't quite reach statistical significance. They didn't comment on intrapartum antibiotic rates, however, which I feel would have been useful. The statistically significant differences were around feeds. More babies in the probiotic group were exclusively breastfed, with 58 versus 48%, and average time to the first enteral feed in the probiotic group was longer. To put this in context, though, we're talking about a median of 2.7 days versus a median of 2.5 days. The probiotic group also took longer to reach full feeds, although again this was a minor clinical difference of 13.3 days versus 12.7 days. They discussed a number of other manners in which their care had changed over the time period, such as alteration of target oxygen saturations in 2011 following the Boost 2 trial, and participation in the SIFT trial. No unit changes that were made had been shown to impact NEC rates, and were fairly standard across the UK. Looking at their results, they found no evidence in the whole group analysis to show lower rates of NEC. In fact, the numbers showed higher rates of NEC in the probiotic group, with 10.6% versus 9.2%, though this was not statistically significant. When they broke them down into subgroups, this was even more notable in those born at less than 28 weeks, with rates of 22% versus 15.3%, and in the overlapping less than 1 kilo group of babies, with 19.8% versus 15.7%, though again these were not statistically significant. They did, however, find lower rates of NEC in premature babies born over 28 weeks gestation, with 2.5% in the probiotic group with confidence intervals of 1.8 to 7%, versus the control group of 5% with confidence intervals of 3.6 to 8.8%, which was just about statistically significant. Looking at their other outcomes, the only significant finding was in the subgroup of premature infants less than 28 weeks. In this group, late-onset sepsis was significantly less common in the probiotic cohort, with 22% versus 30%. Otherwise, there were no really significant findings, and they found no difference in overall mortality from any of the reviewed causes. They also did a binomial logistic regression analysis of the key subgroups, including gestation, chorioamnionitis, and feed type, and again found no significant differences. I won't go into all of the limitations of this article, but one issue within all studies of NEC is that diagnosis of medical NEC is still somewhat subjective and can vary between clinicians and units. The research team did, however, go back to look at X-rays of the babies to confirm diagnosis, and rates of surgical NEC were also similar in both cohorts, which is far less subjective. Given the study spanned several years, whilst the team aimed to identify factors that had changed over the time, it would be impossible to note all. The paper suggests future areas of study, including an important factor that has been relatively unexplored in respect to NEC, the flora of the local neonatal unit, as well as specific unit antibiotic practices. It may be that different probiotics are more relevant to individual units according to their local flora and common pathogens. So coming back to the review article, they take a slightly different perspective and suggest that there is a lot of strong evidence for probiotics in prevention of NEC, citing a Cochrane review on the same topic. But actually that same Cochrane review, which as I said came out before this latest article, is less convinced, suggesting that there may be a benefit rather than that there is a clear benefit, and that more good quality evidence is needed. The paper also suggests more work is needed to look at the impact of maternal probiotics on neonatal outcomes. So far, we've discussed a couple of methods of manipulating the microbiome in a positive way that are already in relatively common practice. But what other methods are out there? The review introduced two concepts that I was aware of, but never considered in neonatal practice, and as yet are to be explored. The first is fecal microbiota transplantation, which have shown good success in C. diff infections, but not yet trialled in neonates in any context. I imagine the ethics approval for that would prove a significant challenge. The second is phage therapy. It involves infecting bacteria with a modified virus to either alter the bacteria's behaviour or selectively kill them. Again, not an area that has yet been explored in neonates and is still in the very early stages in other areas, so a long way off yet, but an interesting prospect. I'll leave you with those thoughts, but I also recommend reading the review in the September issue of Archives, Microbiome and Pediatric Gut Diseases by Gerasimidis et al. There's an episode's worth of material there in its own right. It builds on what I've discussed today, but it goes into more depth and discusses more of the paediatric side of things. Thanks for listening, and as always, please get in touch with any feedback. That's all for this episode. As always, if you have any questions or comments, please feel free to get in touch via our email address podcast@pedshub.co.uk or via the PedsHub website. Equally, if you'd like to get involved, we always welcome your voices, so please do get in touch.
Thanks for listening.